Hi, my name is Emma and I'm the pharmacist today. I just wanted to discuss with you a patient. DS is a 67-year-old male who was brought to the emergency department by his neighbor because of a ground level fall. The patient could not recall the details of his fall but complains of weakness. He does have a history of heavy alcohol use but states he has not had a drink in over a month. Of note, the patient does currently smell of alcohol. About an hour after he was brought in, he admitted to taking an entire 100-count bottle of extra-strength Tylenol, but could not recall when this occurred. He denied suicidal ideation or plan. He is currently in the ICU under a Baker Act with a bedside sitter. He has a past medical history of hyperlipidemia, hypertension, insomnia, AFib, anxiety, and depression. He has no known drug allergies. He denies tobacco or illicit drug use. His mother passed away at age 63 from suicide. His current blood pressure is 191/115. The retake was 202/120. There are a few crackles in the base of his lungs, irregular rhythm, right upper quadrant pain, and abdomen upon palpitation. Pertinent labs include potassium 3.3, CO2 21, glucose 128, but his AccuChecks were 175, 128, and 150. His CPK was 232, bicarb 22.7, INR 1.66, ALT 1,433, AST 1,224, ammonia was 90, phos was 1.7, blood acetaminophen level was 166, and his blood alcohol was 150. His UA was positive for benzos. His current home meds are amlodipine for blood pressure, simvastatin for cholesterol, temazepam for insomnia, citalopram for depression and anxiety, and metoprolol for blood pressure, and rivaroxaban for AFib. He received ondansetron and fluids in the ER. In the ICU, he has been receiving fluids, citalopram, ondansetron, pantoprazole, thiamine, and rifaximin. The top 3 problems for this patient are acetaminophen overdose, hypertensive urgency, and hepatic encephalopathy secondary to alcohol use. For the acetaminophen overdose, our goals are to prevent further toxicity, preserve multi-organ function, decrease mortality, and avoid liver failure. According to the Rumack-Matthew nomogram, he should start N-acetylcysteine treatment. We recommend initiating the acetadote 21-hour IV protocol, the 3-bag method. So the first bag will be 15 grams and 200 milliliters of D5W IV over 60 minutes. The second bag will be 5 grams and 500 milliliters D5W IV over 4 hours. And the third bag will be 10 grams and 1,000 milliliters D5W over 16 hours. After the 21-hour treatment, we will repeat the testing on acetaminophen and AST levels. For his hypertensive urgency, our goal is to keep his blood pressure less than 130/80 per the AHA guidelines. We will restart amlodipine 10 milligrams by mouth daily and initiate lisinopril 5 milligrams by mouth daily. We'll monitor his blood pressure continuously while he's in the ICU, but the patient should self-monitor his blood pressure after discharge daily. He should also follow up with a cardiologist within 2 weeks of discharge to monitor his maintenance blood pressure therapy. For the patient's hepatic encephalopathy, our goals are to reverse the effects and prevent recurrence. We will initiate lactulose 30 milliliters of the 10 gram per 15 ml solution by mouth every 1 hour until at least 2 soft or loose bowel movements are produced daily, and then we'll titrate to maintain 2 to 3 bowel movements daily. We'll change the dose of rifaximin to 400 milligrams by mouth 3 times a day for 5 days. We'll educate the patient to quit drinking completely to avoid further damage to his liver. We'll monitor for mental status changes, bowel movements, BNP, and electrolytes daily while he's inpatient. We recommend that the patient follows up with a psychologist within 1 week of discharge for cognitive behavior therapy to help with his alcohol abuse as well as his anxiety and depression. Thank you.